Thank you. My talk this evening is on plantar fasciitis. My name is Dr. Philip Carolan. I'm a sports and exercise medicine consultant in the sports surgery clinic in Santry. And I'm also the Cavan team doctor for, and are currently the Ulster senior football champions. I've been asked this evening to talk about plantar fasciitis, which is a very common condition and is seen in many areas of life. I know this evening's talk is to do with running injuries, but plantar fasciitis can affect the general population as well as runners. My objectives this evening are to review the pathophysiology of plantar fasciitis, review the underlying causes. There are numerous treatment methods, and I'll go through them and give some evidence-based facts with regard to these treatments, describe a rehabilitation program, and recommend a return to play program. So in my working week, I can see effectively about 20 odd cases of plantar fasciitis. I see patients that have been referred with initial review with an original problem, or patients who've been sent to me with, have already received a modality of treatments and still have not made any headway in getting over the problem. It is a very, very common condition, and I've just shown some statistics here. It affects 10% of runners. It also affects other athletes such as soldiers, soccer players, basketball players. In America, over 2 million patients are treated per year and has a significant interference in the athletic population and in competition. It accounts for between 11 and 15% of all foot symptoms requiring medical care. So as I said, this slide is an overview of what we might see in the clinic ourselves, between 32 to 40 new presentations a week. It's 15% of all the foot presentations, and it's the third most common running injury. So the pathophysiology of plantar fasciitis. The plantar fascia is a big, thick, broad band connective tissue that spans from the heel bone through the arch of the foot into the toes. It originates in the medial tubercle of the calcaneus, which is the heel bone, and inserts in the proximal phalanges, which is the small bones at the start of the toes, and inserts at the flexor sheaths. It forms both the longitudinal arch and the medial arch, and it supports the arch as the weight is transferred over the foot from heel strike to toe off. This is just a schematic drawing of the plantar fascia. On the right is a drawing, and on the left is a drawing, and on the right is a cadaveric specimen. You can see it's a big, thick band tissue that starts at the heel bone and fans out into the bases of the toes. The term plantar fasciitis was the original term, but I classically call it plantar fasciosis because it's a chronic degenerative condition that is characterized histologically by cell changes, i.e. fibroblastic hypertrophy, which are the fibroblasts of the cells, causing inflammation and disorganization of the collagen, which in turn causes you to have an inflammatory reaction and causes pain. So simplistically, it is micro tears of the fascia from repetitive trauma, i.e. repetitive foot strike, that causes degeneration of the collagen. And with the degeneration of the collagen, we try and cause a healing response by inflammation. Hence, it's called an inflammatory response, but really is caused by degeneration. So I call it a fasciosis rather than an itis. In medicine, osis is degeneration, whereas itis is inflammation. So you get cycles of tearing and healing, causing chemical mediators of inflammation to produce pain. That eventually causes myxoid degeneration and weakening of the fascia, which causes painful scar tissue and calcification. And this is what causes the calcaneal spur. It's interesting at times when people come into me and say to me, I have a heel spur, doctor, but that's not actually what's causing their pain. It's more the fascia rather than the bone, because the spur is due to recurrent calcification that occurs during the cycle of degeneration, healing, inflammation. So the causes of plantar fasciitis, there's numerous. It's generally seen in people with high arch feet and flat feet. It's seen in people with a tight plantar fascia, with tight and weak calf muscles. If you can appreciate, the plantar fascia attaches to the heel bone, which is intimately linked to the Achilles tendon and hence intimately linked to the calf muscles. So if you have a tight calf muscle, you invariably have a tight plantar fascia. It's also seen in tight hip flexors. There's also the effect of activity. So it's seen with increased mileage, increased weight, also the type of footwear you're wearing, i.e. Big ram running shoes rather than having a nice heel and shock absorbency. And it's also very common in the HLA-B27 spondyloarthropathies. So we describe in medicine, there's two types of risk factors. There's intrinsic and extrinsic. So intrinsic is what the body is made up of, i.e. your anatomical, your functional, age, and inflammatory conditions. Extrinsic is what happens outside the body. So it's your surface, footwear, and the modality of motion. So anatomical, we talk about the high arch foot or flat foot, pes planus, pes cavus, also about the way your foot strike is. Functional is with regard to the muscles, be it the intrinsic small muscles of the foot, or you have a tight gastrocnemius or soleus muscle complex, and they can be weak as well. The age effect, we talk about collagen degeneration as we age. So as we age, your collagen gets weaker. That causes a weakness in connective tissue. And fascia is made up of connective tissue because it acts like a tendon. So with collagen degradation, it causes weakness, which increases the rate of degeneration. And of course, inflammatory causes, as I mentioned earlier, HLA-B27 seroarthropathies, but also gout is a common cause of resistant plantar fasciitis. So the extrinsic causes, of course, are overload, too much, too often, which causes muscle fatigue and breakdown of collagen. Running gait, as we talk about heel strike, forefoot strike, and of course, footwear. So they're the risk factors for people who develop plantar fasciitis. I talk about intrinsic and extrinsic. We try and talk about the body makeup and the structures that we run on, or the surfaces we play on, and our footwear. So the symptoms of plantar fasciitis is the classical presentation is heel pain first thing in the morning when you get out of bed. This may improve through the course of the day, but tends to hurt again by afternoon and evening. It reoccurs upon standing after prolonged sitting, and it's worse with walking barefoot and walking upstairs. So it's not a very difficult area to do a physical examination on, because most patients describe tenderness to the palpation on the anteromedial aspect of the heel, with ankle dorsiflexion is limited by calf tightness, and they also get pain increased by great toe extension or by standing on their toes, and this is known as Wimslow's test. So this schematic shows the areas that we would see most frequently affected by pain with patients who have plantar fasciitis or fasciosis. I think it highlights the central area on the posterior aspect of the heel or the posterior back of your foot, where 52% is just right on the medial attachment of the plantar fascia, and it can radiate out among the medial, central, and lateral branch. We do get patients who have pain in their forefoot. That generally acts like a nodular plantar fasciitis. We get like lumping in the plantar fascia rather than a pure inflammatory response. So the differential diagnosis that I would deal with when I see patients with heel pain are especially patients who are doing a lot of mileage or calcaneal stress fractures, fat pad inflammation, so that you can appreciate the plantar fascia acts like a sling or a strut to support the medial arch. And then under the plantar fascia, there's a layer of fat to give cushioning and protection to the whole foot structure. And at times you can get fat pad inflammation or changes in the fat pad that can mimic the pain of plantar fasciitis. Also, there's a tendon that runs very closely to the medial arch called the tibialis posterior tendon, and it can also get injured. One of the things that can commonly mimic plantar fasciitis is medial calcaneal nerve entrapment. And I would normally look into medial calcaneal nerve entrapment if I have a patient that is really struggling with the treatments we've used and still is struggling with quite severe heel pain. So radiology, this is there any value in doing X-rays, MRI, or ultrasound? And lots of patients I would see would come in with an X-ray report saying they have a calcaneal spur. So I normally would start off, it's rarely useful, not needed in most cases. And then you get the question, what about the heel spur? I think they're probably negligible. There's about a 13% prevalence and they don't cause any pain. And as I showed there, only 5% of those with a calcaneal heel spur complain of heel pain. I think the use of radiology really is for three main issues: is the diagnosis of a calcaneal stress fracture, especially in people who do a lot of running. And also, we get a lot of patients who've had chronic plantar fasciitis who present with quite severe heel pain, and it's very useful in diagnosing a tear in the plantar fascia. So as I say, what I use MRI to confirm is an inflammatory response, enthesopathy, an intrasubstance tear, or just chronic thickening of the fascia. So the inflammatory response, you'll see a thickening of the plantar fascia with some inflammatory cells on the dark layer of the plantar fascia. Enthesopathy, this is where a tendon or the plantar fascia itself tugs on the bone where it's attached, and it'll cause some bony bruising or bone edema in the heel bone, which is a sign that both bone and fascia pain are together, and this is more difficult to treat. An intrasubstance tear, you will see that on MRI because you'll have a fluid layer within the plantar fascia, and then the chronic events or the chronic people, you'll see a big thickened plantar fascia and possibly some bone edema. So regard to the helpfulness of this modality is that under the layer, that line of inflammation, enthesopathy, we have an idea of what sort of exercise program we might put them on, i.e. intrinsic exercises for their foot, concentric and eccentric and posterior chain exercises. So we break them up again in what we would feel is the best modality of treatment, i.e. depot, which is a steroid injection, ESWT, which is shockwave therapy, ACP, which is platelet-rich plasma, and chronic that has had some treatment done already, put them in a boot. On the bottom there, you can see I've put in surgical. In my 12 years of dealing with plantar fasciitis, or 13 years of dealing with it, I haven't sent on anyone for surgery for their plantar fascia. This is just an MRI scan of a very thickened plantar fascia, just under the heel bone, and you can see some white area in the heel bone, and that's enthesopic changes. There's a small tear in that fascia, and I would be recommending to that patient that they would have a platelet-rich plasma injection. So that brings me on nicely to treatments. And I get a lot of patients who come into me and they've had some form of treatment done already, or they've gone to foot solutions and have had orthotics made and they're getting no better. So I start off with a simple algorithm that I use, and I tick off the boxes that have been covered or not covered and move on from there. So if running and a lot of physical activity is causing them to have severe heel pain, the first thing I tell them is to modify the activity they're doing and give themselves more rest time. There's a talk about shoe inserts, orthotics, taping, supportive shoes. I do believe with taping and some form of shoe inserts. As I mentioned earlier, one of the causes is high arch feet and flat feet. I'm very easy with regard to orthotics. I just recommend to go out and get simple over-the-counter arch supports. It offloads the medial arch until their heel pain settles down, and then you can make a diagnosis with regard to an altered gait or other gait to prescribe orthotics. One of the great treatments out there for early stage plantar fasciitis are night splints, and I would prescribe this regularly for a new patient. The stretching programs involve arch, calf, soft tissue, massage of the calf, and ice. We use non-steroidal anti-inflammatories early on, but I wouldn't recommend keeping people on non-steroidal anti-inflammatory medication long-term. And then we move into the interventional stuff that we would regularly use in Santry, either steroid injection, shockwave therapy, or platelet-rich plasma injections. So the principles of the rehabilitative exercises, you need to have overall flexibility in and put less strain on the plantar fascia. So you need the Achilles to be flexible, the longitudinal arch should be flexible, and the calf. So that involves working on the intrinsic foot muscles, ankle stability, and also looking at the way you run to try and reduce the amount of forces that are going into your heel by causing relaxation and greater calf strength and flexibility. So I would normally talk about Achilles stretching once to twice a day, hanging over the edge of the stairs, barefoot heel toe backward walking while carrying weights, towel toe grabbing for the intrinsic foot muscles. And these are the mainstay of the rehabilitative exercises. There was an interesting paper in the British Journal of Sports Medicine recently where they looked on loading the plantar fascia with intrinsic foot exercises, and it had some effect early on in healing, and the paper was called Load Me Up, Scotty. So it's another one of the newer research has been done on plantar fascia pain. So I would normally say to patients who initially come in to see me, before you get out of the bed in the morning, get a towel, put it around your foot and stretch the plantar fascia for a number of minutes prior to getting out of the bed. Because as I said earlier, the plantar fascia acts like a tendon, and it shrinks at night. So when it shrinks, if you put weight into it first thing, you stretch it, and that causes severe pain on an inflamed or injured tendon. So if you stretch it or get it activated first thing in the morning, before you put it in the ground, the pain will be less obvious. Also, we talk about running a golf ball or a tennis ball, or as this image shows, a tin under the heel of the foot, or under the foot, it helps stretch out the plantar fascia. I suppose it's a form of an oxymoron in the sense that one thing we're saying that the plantar fascia is a strut, and yet we're saying we can stretch it. Both cases are probably true. It does act as a strut to the medial arch, but it also shrinks and acts like a tendon, so it can stretch. So as you can see, the slant board stretch and the stair stretch act like the eccentric exercises from Alfredson for the Achilles, but they're very beneficial in treating plantar fascia pain. So I mentioned about the night splint. I'm a firm believer that the night splint is underutilized in the treatment of plantar fascia pain. It's a splint that keeps your foot in fully dorsiflexion at night, so it prevents the plantar fascia from shrinking. There's different variations out there, and I've shown a number of splints, and also the sock third over on the right is known as the Strasbourg sock, and it's less cumbersome than the boot, and a lot of patients find it more comfortable at night. But this would be one of my mainstays of treatment initially for a new patient with plantar fasciitis. There's been a number of studies performed on the night splint, and Bat et al. And Probe et al. In 96 and 99 showed that with the tension night splint and heel cupping, in 100% were cured, and ones that failed with non-steroidal anti-inflammatory stretching and shoe changes, a tension night splint improved their outcome. So there's mixed results, but I would always use it first off. Orthotics. This is a very difficult topic to talk on its own. I'm not a firm believer in prescribing orthotics when people have a normal gait and don't have a normal foot strike or biomechanics because of severe heel pain. As I said earlier, I would normally recommend that the patient would go out and buy simple over-the-counter arch supports to give the arch a little bit of support as they are going through a rehab program. There definitely is no evidence to show that getting custom orthotics improves the rate of healing of people with plantar fasciitis. As I said, there's been a number of studies out there in 1999. They randomly assigned patients to 5 different groups, and over-the-counter arch support full length felt 81% noticed a good improvement. With the custom 3/4 length poly orthotics, only 68% noticed an improvement. The problem with that study was that there was only 3/4 length orthotics used rather than the full length over-the-counter arch supports. So that moves me on to interventional modalities that I would use, because most of the patients have tried a lot of the stuff that I've mentioned earlier with regard to physiotherapy, calf stretching. And so I would then discuss the types of treatment that I would use, which is extracorporeal shockwave therapy, steroid injection, or platelet-rich plasma injections. Extracorporeal shockwave therapy is non-invasive. It involves using a gun like the pictures here, and you deliver a certain dosage of shocks at 10 hertz frequency, and you increase the bar of pressure to allow, as patients can tolerate, up to a pain scale of 6 to 7 out of 10. The modality works is it's a cascade effect. So you put the probe onto the degenerative plantar fascia with the energy transferred across the fascia. It causes and activates a healing cascade response, which enhances blood flow into the tissue, which causes tissue degeneration or tissue regeneration, apologies. So we would normally do shockwave 3 to 4 treatments a week apart, and then get the patient back 2 to 3 weeks after that for a top-up treatment. I find shockwave a very good modality. It's non-invasive, and lots of patients do very well with it. The next option is a corticosteroid injection, which we would do under ultrasound guidance. This is an image of the ultrasound probe and a needle being directed at the plantar fascia, and you can see the ultrasound image on the right-hand side. You can kind of see a little mountain in the middle of the image, and the thickened gray part on top of that is the plantar fascia. I'm slow at recommending a steroid injection straight off. There's definite evidence that it provides quicker pain relief at 1 month, but there's no long-term advantage. There has been a number of studies that have shown that steroid injections, there is a recurrence rate of 45 to 50% at 6 weeks. And the big risk with using steroid is that it is toxic to the plantar fascia, and that it may cause tendon or plantar fascia rupture. In the olden days, this is the only treatment we had, and it was regularly used and was successful. But as I say, the statistics show that 1 in 2 have a recurrence rate at 6 weeks. And a newer treatment that we've started using is platelet-rich plasma, and we use the Arthrex ACP separation kit. What we do is we take blood out of your arms, spin it down in a centrifuge, and then under ultrasound guidance, inject that back into the plantar fascia. The biggest problem with the plantar fascia platelet-rich plasma injection is it does involve a certain amount of immobilization. We put you in a boot for 2 weeks pre-injection and 2 weeks post-injection. So I would generally use this for patients who have a tear in their plantar fascia, or for patients who have chronic fasciosis, and have not seen any result with any of the treatments they've been offered to date. So what it is, it's purely simply whole blood that is centrifuged, that is spun down in a machine to create an increased concentration of platelets with or without the white blood cells. So on the image at the top of the screen, you can see nice golden, clear golden fluid at the top. That's the enriched plasma. And at the bottom, that's the separation layer of the red blood cells and white blood cells. So what's so special about platelets? They activate various growth factors within the tissue, and that makes them special because it enhances an inflammatory response to promote healing and repair of the damaged plantar fascia. The effects of the growth factors on tissues, there's 3 different factors. There's the immediate. It causes a second messenger stimulation, i.e. the macrophages stimulate the tissue to cause interleukin response to cause a healing. That's within 5 minutes. Then early, between 30 minutes and 4 hours, you get messenger RNA stimulation to cause protein synthesis, and chemotaxis of further healing enzymes to the tissue to promote further healing. And then the late responses, within 24 hours, you get fibroblast mitosis, which then encourages collagen deposits and the rate of healing of the damaged plantar fascia. So PRP is not stem cells. We get asked this all the time, is it stem cells? It's not lipocytes, and it's not bone marrow. It's simply platelets in plasma that promote an inflammatory response to promote healing and repair. As I said, it promotes inflammation. So the reason we put you in the boot is to try and let things be absorbed and adhered around the plantar fascia and let things rest for a period of time so there's better uptake of the plasma. We don't allow patients to use anti-inflammatory medication for 72 hours after the injection because it stops the cascade inflammation reaction that does promote the healing of the plantar fascia. It's effective in chronic plantar fasciitis and in tears of the plantar fascia. There's lots of papers being written and they all seem to highlight that plantar fascia pain that has not succeeded with other treatments do very well with platelet-rich plasma injections. So my typical treatment protocol for new patient, so I profile and try and limit the amount of activity to control the abuse of the fascia. I normally give them 2 weeks of anti-inflammatory medication. I talk about ice massage and rolling the medial arch up to 4 times a day. Over-the-counter arch supports, give them a handout on exercises to work on their calf, Achilles, and the plantar fascia, and follow up in 2 weeks just to reinforce whether they're doing their exercises, get an MRI to see how badly damaged the plantar fascia is, and then discuss interventional therapies. There are unusual things that can mimic the plantar fascia, as I mentioned earlier, and if patients are still suffering from pain after 3 to 6 months and not responding to treatments, which I may say I do have times throw the kitchen sink at plantar fascia pain involving all 3 modalities of treatment, and if at that stage they haven't responded to treatment, I would always think of other conditions that may mimic it, some like a fibrosarcoma of the tissue, a foreign body within the plantar fascia that's not evident on X-ray or on MRI. The older diseases like Paget's disease or TB, and also gout. As I mentioned earlier, gout is one of these arthropathies that can cause plantar fascia pain to linger, despite throwing a lot of treatment in it, and a simple uric acid blood test and treatment of gout gets rid of the plantar fascia pain. The one thing that I see quite regularly is when I've thrown a lot of treatments at the plantar fascia is a nerve entrapment syndrome. I've, in the past year, would have seen probably 6 or 7 nerve entrapments of the medial calcaneal nerve and accessory sural nerve. So if treatment is not going well, I would normally refer these patients on for EMG studies and getting the entrapped nerve flushed with saline and local anesthetic generally helps relieve the pain. Prognosis. The prognosis is excellent for plantar fascia pain, although patients I see who have it don't feel the prognosis is good because they've had it for so long. 80% are generally better in 12 months. The literature explains that it is a self-limiting condition and it can burn itself out, but they cannot put a time frame on it. Most patients who get no treatment and get by through the pain cycles generally would say to me that after 3.5 years that it would burn itself out. We have treatments there to try and help patients, and anyone I see, I would start them into a treatment plan to try and reduce the amount of time that we suffer from heel pain. Surgical intervention is very rare, and I don't think, as I said, I haven't referred anyone for surgery over the 12 years that I've been involved in treating plantar fascia pain. So the take-home messages from this talk is that plantar fasciitis is very common. It's a degenerative condition and not inflammatory. Strength is key. What I mean by that is that your calf muscles and your Achilles need to work synergistically to take the load out of the plantar fascia. Adjuncts do help. The heel raises, the soft heel gel pads, and over-the-counter arch supports are all very beneficial in trying to help reduce the pain. Segmental load is used to offload. So as I said, that new paper in the British Journal of Sports Medicine, Load Me Up, Scotty is trying to load the plantar fascia early so it reduces down the pain. So that is a new paper that may show added benefit over the next number of years. And as I said earlier, I would normally use shockwave therapy or platelet-rich plasma injections, and that surgery and steroid treatments are rare. Again, I'd like to thank you for letting me give you this overview on plantar fasciitis. I can tell you I'm a sufferer of the condition myself. I had it for a number of years, and I understand and empathize with patients who have it. As I said, I'm a sports and exercise physician, and I work in a sports surgery clinic. And this is a final slide of myself with 3 of the physios who work in the clinic. We're all involved with the successful Cavan Ulster Champions of 2020. Thank you very much, and I'm more than happy to take any questions from you.